We'll be now transitioning to the healthcare barriers and experiences for LGBTQ people with disabilities using data and storytelling to address disparities. I think this will dovetail very nicely on what we heard in the last session. I'm really excited to introduce our two speakers. Oh, I should introduce myself as well. My name is Ken Sutha. I am co-chair of SMATI. I am a 40-something Southeast Asian male. I'm bald. I'm wearing a purple button-down shirt and I'm in front of a virtual background of the Stanford Children's Hospital. Again, I'm excited to introduce our two speakers. First, we'll be hearing from Shane Lamba. He's a research assistant with Stanford University's The Pride Study and PrideNet research program, where he serves as a co-investigator for a research study examining healthcare access, barriers to care, mental and physical health functioning for lesbian, gay, bisexual, transgender, queer questioning people with disabilities. In addition to his work at Stanford, he works full-time with the health systems specialist at the Department of Veterans Affairs, Office of Health Equity, where he conducts research and evaluation activities addressing health disparities for minority populations of veterans. Next, after that, we'll hear from Cameron T. Whitley, PhD. Dr. Whitley is an associate professor in the Department of Sociology at Western Washington University, where he studies issues concerning environment, human-animal interrelationships, and transgender-affirming medicine. Dr. Whitley became interested in trans-affirming medicine in graduate school when he was diagnosed with kidney failure and received a kidney transplant. After receiving his PhD and a donated kidney, he co-authored one of the first articles addressing discrepancies in kidney function evaluation for transgender people. I'll hand it over now to Shane.
Thank you so much, Dr. Sutha. Good morning, good afternoon, everyone. Let me just share my slides here. And I realized my monitor is not going to want to work for my secondary set, but I will share the slide set right here. Let me do that, and we'll start from here. Great. Can folks see the slides here? Perfect. Well, thank you so much, Dr. Sutha, for that introduction. Again, my name is Shane Lamba, research assistant with the Pride Study here at Stanford University. I'm joined with Dr. Cam Whitley today, and we'll be doing like a two-part session, but I was going to pass it over to Dr. Whitley if they wanted to introduce themselves briefly before we kind of jump in.
Great. Yeah. My name is Cameron Whitley. And let me just tell you a little bit, describe myself a second. I'm a white transgender man. I have a blue shirt on with polka dots, light brown hair, blue eyes, black glasses, and I'm in my office here at Western Washington. You can see my window behind me with the rain coming down. So I'm excited to be here, and thank you again to Shane for doing this first part, giving us statistics. The last thing I'll say is I think it was Allison Kessler who said, the numbers are nothing without the story. So Shane will give you some of the numbers and I'll fill in the story in this. Thank you.
Wonderful. Yeah, thank you so much. And I will give a visual description as well. I'm an Indian American man in his late 20s wearing like a floral blue button-down shirt, although you can probably only see the collar here. I have a thick mustache, thanks to growing it out for a little bit, with brown glasses and dark brown hair that's styled. So with that, I'm actually going to jump right into our talk since we have a jam-packed session. And as Dr. Whitley had mentioned, my part is essentially kind of building our story of using that data. And I'm really excited for Dr. Whitley's part about the storytelling because I think it echoes a lot of the earlier sentiments that speakers have mentioned in terms of trying to understand what disparities look like for LGBTQ people with disabilities by understanding the data and then using the lived experience information. I have no disclosures to report or conflicts of interest. And I want to just briefly mention some of the learning objectives for today. So by the end of today's conversation, you should be able to describe sexual and gender minority or SGM healthcare disparities. You might be wondering what the term SGM is. It's a very similar or synonymous term to LGBTQ+. In efforts to not make the alphabet soup with the longer acronym, I wanted to kind of use the SGM acronym and also kind of bring light to the fact that often in research and academic settings, SGM is often the acronym of use. Also, by the end of today's session, you should be able to explain some of the effects on the intersection of SGM and disability identities. And then also we're going to assess healthcare disparities with storytelling and lived experience data, which will really add on to our knowledge. So with that, I actually just want to start with some general disability related disparities, which I'm sure I'm speaking to the choir here for folks who are immersed in the community and immersed in their literature or the research field, or even in the medical care frontline staff field. But I thought for today's conversation, it really helps us kind of build the why we're doing this and why we're going to be talking about the healthcare barriers. So about 26% of the US population live with a disability. So that's about 61 million adults, which was from some CDC data. Additionally, the CDC has really looked at some surveillance information from federal and state levels and found that racial and ethnic minorities, women, as well as older adults are often at a higher risk for living with a disability. We also are aware from the CDC and some other research studies that people with disabilities are about 2 to 3 times more likely to have unmet needs and often are less likely to receive adequate medications. Moreover, about a third of those individuals do not have access to a regular healthcare provider, which really brings about several barriers to care and kind of is supported by some of the literature and some of the most commonly reported being affordability of care, transportation issues, as well as insurance coverage and also accessibility. These things are really pertinent to understand and also sometimes a little bit unique with respect to affordability of care and insurance coverage, especially here in the United States, where we don't have a socialized healthcare system. And I bring this up because I know we might have folks from across the globe where socialized healthcare might be present, and just wanted to bring that up and raise some more awareness of like how these barriers potentially might be existing here in the US, but may not be existing at higher rates in areas where socialized medicine is present. So with those kind of differences and statistics in mind, I want to dive right into some of the SGM health disparities to really build our case and to support some of the literature, support some of the data that we're going to be discussing in the next several slides. So within the SGM and disability research space or data space, there really is limited information. We don't really know too much about this population embedded within the LGBTQ community. But from what we know, we can kind of draw some connections and parallels to some of the broader disability general population information. But with that, some of the studies that have revealed that SGM people with disabilities often experience heterosexism as well as ableist microaggressions that have a profound impact on mental health conditions such as depression or even PTSD. Eliason and colleagues in 2015 worked on researching how SGM women with disabilities experience certain stressors, mental health issues, as well as environmental stressors. And they found that SGM women with disabilities faced higher rates of discrimination, post-traumatic stress disorder, as well as anxiety issues. And reasons for that often stemmed by other literature and supported by other literature were related to the barriers of physical wellness, emotional health, as well as functionality and social engagement, which are more of those upstream structural issues that might be affecting one's engagement to promote positive health, as well as positive health outcomes. And lastly, we know that SGM people with disabilities were more likely to delay care, often because there's a lack of education and culturally competent providers or even healthcare systems, right? So at a system level, there's inadequacies in the way that provider education is rolled out on top of staff education. Individuals have reported that providers are not really sure about how to navigate one's multiple identities. So really echoing that concept of intersectionality and the fact that they're not really aware of how do I treat an individual or how do I work with somebody who might be LGBTQ, but on top of that, also living with a disability. So the educational gap is there, and something that we need to be more aware of in the community. But also, I think it's very similarly seen in just the general disability community that providers are often a little bit uncomfortable or not as readily available to access and work with patients to address their barriers or address their unmet needs. So before we jump in, and so hopefully some of that literature kind of framed the case and gave you a little bit of a flavor, I would say, for the SGM disability disparities. What I'm going to do in the next several slides is share some really cool data from the PRIDE study here at Stanford. But before I jump into kind of the study data, I want to share a little bit about how this study came to fruition. So I've had a very deep-rooted interest in understanding disability-related health as well as just disability justice. I think it really stemmed from my experiences seeing my mom as a special education teacher and really being immersed in her classroom as a student. I saw how the principles of like equity and inclusion were really promoted in her classroom, and I wanted to think about how that can be translated into health and healthcare. It's because of my mom's education classes that when I was engaging with her and volunteering in her classes, that I really learned how important inclusion and equity is. And it's really stemmed my interest in LGBTQ health. My predominant field of interest is often healthcare access and trying to understand how we can mitigate those barriers. But I think the added layer of my experiences of equity in my mom's classroom, while it's not education driven with the research that I'm doing, it still promotes that concept of, creating an opportunity that is inclusive and equitable at the end of the day. Also being part of the community myself, in the LGBTQ community, it's really great to see someone like myself who's Indian and open and out to be part of a study. And so it's really rewarding to be part of this program to present some of this information. So I will jump away from my soapbox, but I did want to just kind of give some little heads up of how this study came to fruition. But I'm really excited to share a lot about the results from our study. We recently published in the American Journal of Public Health and looked at data from our PRIDE study, specifically the 2019 annual questionnaire. And before I jump into the next couple of slides here, I just want to give a little preface of like the PRIDE study for those who may not be aware. The PRIDE study is an online longitudinal cohort study of SGM or LGBTQ people across the United States. Individuals participate in an online method. So it's an online survey that gets sent to them, and participants are asked to complete it every year. There's also a lifetime survey, which evaluates a variety of social, physical, mental, as well as environmental health factors. So with this, we use the data from the 2019 annual questionnaire to really evaluate how healthcare disparities and healthcare barriers exist for the disability population. So I'll jump into some of our data here. And again, this data is coming from the 2019 annual questionnaire. About a third of our cohort self-identified as living with a disability. From the 2019 annual questionnaire, we had about 5,000 individuals. So about 1,500 of those individuals self-identified living with a disability. And some other information about demographics, compared to those without disabilities, SGM people were younger. They are more likely to be unemployed, to be white, have lower income, and to be non-cisgender. When we looked at some barriers to actually delaying care, we found the following. About 14% of SGM people with disabilities did not have health insurance in the past 12 months. Those with disabilities are also about 3 times more likely to delay care due to disrespect or mistreatment in the past 12 months compared to those without disabilities. And about a fifth of those with disabilities in our cohort were denied or given lower quality medical care compared to 6% of those without disabilities. Again, kind of confirming some of the similarities that we saw in the general disability population. But when we move kind of the needle towards healthcare access, so figuring out what is kind of the proxy of why people are delaying care, we also found some significant barriers in the access realm. We found that about 69% of SGM people with disabilities have a usual place of care compared to about 3/4 of those without disabilities. Usual place of care included like an ER, an urgent care, primary care facility. And what was really interesting from our findings was that there was no significant difference between having a disability and having a primary care provider. Although those with living with a disability were more likely to see their primary care provider in the past 12 months. So there seems to be some interesting relationships with the concept of having a primary care provider having a usual place of care, and then also delaying care, where often we think of having a primary care provider as a good proxy to meet people's needs in the healthcare facilities or healthcare in their healthcare. That wasn't necessarily the case in our study. And what we really found when we ran some regression models to truly understand some of these differences, we categorized our participants into 4 categories to run separate individual models. We wanted to see what were the odds of people having a primary care provider or being uninsured, but we also looked at them by different disability types. And we used a categorization system by the CDC and also adapted it from some literature and put people in 4 categories of physical disabilities, mental disabilities, intellectual, as well as other. And what we found was really interesting. We found that, again, SGM people with disabilities were about 1.5 times more likely to have a primary care provider. They were also more likely to be uninsured in the past 12 months. And this also kind of varied by the different types of disabilities. But what was really salient and kind of puts the kind of onus on like what we can do next to understand is what we saw when it came to delaying care or being unable to obtain care. SGM people with disabilities across a variety of groups were about 3 to 8 times more likely to delay care in the past 12 months. They were also unable to obtain care. So like I mentioned earlier, there's an interesting relationship with having a primary care provider, having to delay care or be unable to obtain care due to disrespect or mistreatment. But when we asked folks why they delayed care, most commonly reported were, again, affordability, insurance coverage, and appointment availability. So really echoing, I think, a lot of what people have been talking about in the earlier session about raising awareness for policy implications. And I think our study really adds on to the literature to help us understand that the SGM community is experiencing similar trends of what people in the general disability community are also experiencing, but there's that added underlying intersection of their sexual orientation identity or their gender minority or gender identity status. And with that, I want to kind of share some policy implications from our paper and where we want folks to think in the future. We have a great audience filled with individuals who are advocates, people who are in the community, people who are interested in this work. And I think it's really important for us to share kind of these next steps. What we found in our study essentially were that SGM people with disabilities were more likely to delay care because of disrespect or mistreatment. We found that research is really showing the disproportionate, the research is confirming what we found in our study, right? SGM folk are disproportionately experiencing discrimination, bias in healthcare settings due to a variety of factors, such as provider lack of knowledge, as well as health systems' inability to really address these issues from a structural perspective. But there's also fears of discrimination, which often are related to their multiple intersecting identities. What people can really consider, or what we should be considering, is more cultural competency trainings that are mandatory, right, for healthcare providers or healthcare systems to really impart a welcoming and inclusive environment for the SGM community. So it can hopefully deter them from delaying care in the future. We also want to advocate for policy changes, right, that affect the barriers to care, such as affordability, appointment availability, as well as accessibility. So these are some of the policy implications that we hope folks can take forward with our study that we published in AJPH. And before I pass it over to Dr. Whitley here, I just want to briefly go through some of our unpublished data, which is currently under review with a journal that looks at mental and physical health outcomes. And the reason why I want to share some of these slides here with some of the data is, we spoke about the healthcare barriers that are present. However, I think it's really important for us to understand how these healthcare barriers, such as access or delaying care, translates to our health outcomes in this group and how those two might be related. When we looked at certain mental health outcomes, such as anxiety symptomology, we looked at the GAD-7, which is the Generalized Anxiety Disorder Scale. We essentially ran some regression models with similar disability groupings and found that SGM people with any disability had about 3 times higher odds of having a clinically significant score. What this really means when it comes to the literature and our study. We know that SGM people experience a lack of social support, disability, or even SGM-related stigma, as well as have poor access to mental health. So understanding the kind of relationship between having these barriers as well as seeing higher rates of anxiety symptoms really allows us to draw a picture and say, hey, this is a problem. We need to address it because we can easily rectify certain issues that are related to actually accessing care than we can right away with imposing different types of training and education to improve social support systems, as well as improve stigma and stigmatizing language in healthcare settings. The similar notion kind of goes along with depression symptoms. We found that SGM people with any disability had about 3.2 times higher odds of having a clinically significant PHQ-9 score, which is the patient health questionnaire. And I would also want to add on here that SGM people experience heterosexism, exclusion, lack of culturally sensitive providers, as well as little to no social support systems, which often can cascade and show and present themselves with worsening mental health outcomes. So again, it's really important for us to consider that the higher prevalence of these barriers that they're existing and experiencing in the healthcare system may have an impact or a role on the way that their anxiety or depression scores or symptoms are presenting themselves. And with the speed of time, because I know I'm closer to my time here and I do want to pass it over to Dr. Whitley, I'm going to just skip this slide here and move over to the overall conclusions. But overall, SGM people with disabilities experience significant healthcare barriers, right? We noted that there were about 3 to 8 times higher rates across all 4 disability categories relative to folks without disabilities. Our study really confirmed that the previous research on cost, insurance, and appointment availability were one of the most commonly reported barriers for SGM people as well. So there seems to be a relationship and a similarity that we can really leverage in our advocacy. However, SGM folk also had worse mental health outcomes, really positing this relationship and promoting the idea that we need to do better when it comes to bridging the gap with the healthcare access barriers that have an effect on mental health outcomes. And future researchers that are in the audience here or folks who are interested, we really push folks to think about the subgroup level data, right? Not only think about the large group in its entirety, but think about how folks with different sexual orientations as well as gender identities may experience certain healthcare barriers. So with that, I will show you a little snapshot of my references. And then if you're interested, please feel free to contact me and stay connected. And I will pass it over to my wonderful colleague, Dr. Cam Whitley, for their session or part of the session.
Wonderful. Thank you. Thank you, Shane, for sharing some of those statistics. I want to let everyone know that I'm recovering from a cold. So if I start coughing, that's what's going on. I do have a cough drop, so we should be okay. For the next 10 minutes or so, I'm going to share components of my story that parallel some of the stuff that Shane talked about. You can go ahead and move the slide. So I'm really into imagery and storytelling. That's what I do as a sociologist and a lot of the work I do. So I'm going to try to really tell you about the images that I have here. The top right corner is an image of me when I was 2 years old. I'm in the hospital and I had Kawasaki's disease. And then the bottom right is a picture of myself and my wife and our 2 dogs. We now have a child. The child is not pictured in that image. And this slide is titled History and Diagnosis. So as a reminder, I am a transgender man. I was diagnosed with stage 4 kidney disease around 2015. I had previously had Kawasaki's disease as a child. I am also neurodivergent. So my perspective comes from not just being a patient, but also being a researcher. I was in my final year of graduate school in Michigan working on my dissertation when I went to the doctor for the most excruciating ear pain I have ever experienced in my life. They did a bunch of lab tests and different things, and my lab numbers were concerning, my blood pressure was concerning, and I was immediately referred to a nephrologist. On our first meeting with the nephrologist, I was informed by the nephrologist that she had talked to my primary care physician and determined without ever talking to me that I would be taken off of testosterone. At that point, I had been taking testosterone for about a decade. So this was devastating news. They had concluded that my kidney disease might be because of taking testosterone, because sometimes bodybuilders experience kidney disease because they're taking steroids. So for those who can see me, you can tell I am not a bodybuilder. For those who cannot see me, I am 5 foot tall. I am about 120 pounds. I am slender. I am not at all a bodybuilder. Okay. You can move the slide. So this is what we call trans broken arm syndrome. And that's what this slide is about. I have a comic up here where the doctor is saying, "Hi, I'm Dr. Douglas. What seems to be the problem?" And the patient says, "I woke up this morning and my arm has fallen off." The doctor says, "I recommend stop taking those hormones." And the patient says, "I'm here about my arm." This is what it feels like to be a trans person with a disability or multiple disabilities, trying to navigate the healthcare system. And this is for all trans people, honestly, even when you don't have disabilities. This has happened to me countless times. As Shane mentioned, SGM people can be reluctant to seek medical care. And this is one of the key reasons that I am reluctant to often seek medical care. This also means that whenever I travel, whatever I do in my day-to-day life, I often map out where I can access competent care. Because there's been a number of times when I've been at ERs or different places where they have simply said, "We can't help you because you are on testosterone or you're transitioning or your case is too complicated for help." Change the slide. So this slide says hormone replacement therapy and research. And what I did on this slide was give images of 3 articles that I have either been a lead author on or been included in authorship on. So at one of the hardest times of my life, where I was given a literal life-threatening diagnosis, my testosterone, the thing that has guided me and helped me not feel depressed and anxious and suicidal in my life, was taken away from me. I'm not going to share all the things that happened to my body because of that determination by my doctors. But what I will say, it was physically horrendous and mentally horrendous. And it in that process made me depressed and borderline suicidal. So as a researcher in training at the time, I asked, what research is guiding your decision? I wanted to know what is backing up what you're suggesting here. And I was told, well, we just don't know. There's not any research about trans people and kidney disease or how we evaluate this. So I went to the articles and I started reading hundreds of articles about hormone replacement therapy, how it's processed. And then I read hundreds of articles about kidney health and how we evaluate kidney function, and tried to kind of understand, where do trans people fit into this dialogue. Then I went to work to analyze my own results and ultimately determined that some of the ways that we are measuring kidney function for trans people are not adequate, and that we're often just dismissed or not even included in those calculations because they're so binary, they're either male or female. So in that process, I then cold emailed the only academic I knew working on looking at laboratory medicine for transgender patients. And I didn't expect her to respond. I mean, here I am, a graduate student in sociology. I'm reaching out to this major medical professional to say, "Hey, can you help me here?" Right? She did respond, and that's how we ended up writing the first article that looked at kidney care for transgender patients and how we evaluate that. Since then, I've been really fortunate to be included as a patient partner on a number of studies that have done this work, and this is really exciting to kind of see this evolve. Ultimately, what happened in my circumstance is my wife is also an academic, so she took a job in Philadelphia where I could get really good trans competent kidney care. And that's one of the main reasons that she took a job there. Slide change. So in this slide, what I want to talk about are the research ethics and talk about how, as researchers, we think about LGBTQ people. So we talk a lot about how we need to include LGBTQ people, specifically those with disabilities, in more studies. But also, sometimes those studies have problems in terms of maintaining anonymity. So I wanted to talk a little bit about my experience. So it's often the case that patients aren't often involved in this work, but when you work with trans patients, they are often, I would say, at least those of us who are 30 or older, aware of some of the dialogues that are happening in medicine, because we have often had to educate our providers about our own care, and often had to do that in order to maintain using testosterone or using hormones or other resources. So often my medical appointments now are, hey, have you read this latest article? What are you working on? So there's this back and forth that's kind of an interesting dialogue as a patient, but also as a researcher in this way. So a couple of years ago, I woke up to a barrage of emails and text messages asking if I had read the latest article that came out in the American Journal of Transplantation. It was only 8 in the morning, so I was like, no, I haven't read that. But my friends and colleagues at the time were sure that the transgender man in his mid-30s who had previously had kidney disease and was highly educated was probably me. There was no real denying that, right? Yep, there's not many trans men out there who have had kidney disease, who are in their 30s, who have had a transplant, and they listed a number of other things. So my amazing transgender competent team at a leading research university had published an article using me and a few other people as case studies. I didn't mind this. I'm happy to see my case be reviewed and used in studies. What I did mind was the intimate details about my life and medical history that had been shared with friends and colleagues around the world, some details that I never wanted shared, and details that weren't medically necessary to the case or to understand the equations to calculate kidney function. In the preceding weeks, I received some angry emails and even a few death threats. One person even suggested, quote, a perfectly healthy organ had been wasted on you. I'm not angry at my team. I am a researcher as well. So there's a fine line between presenting a case and making sure anonymity is maintained. In this case, I don't think that the team had a transgender person on their paper or consulted with transgender people to assess the positive and negatives or what this could mean in terms of anonymity. The other piece of this, I know for some of you you have heard that I did receive threats, death threats. And for some of you that might feel really scary, and it is scary, right? But for many of us in the queer community or the LGBTQ community or SGM, whatever term we use, death threats are a reality. And for those of us who are trans and who are very out in public, it's more of a reality. And so you could see me kind of brush it off, but that's a reality of my life and the work that I do, that it happens no matter where I'm at or what I'm doing, which is also a reality of why I have to be careful in terms of seeking medical care. So on this slide, what I show are the two articles, the one that was published, and then we wrote a rebuttal to the article that was published. And the rebuttal does not even address the anonymity concerns. It actually addresses some other things that were not exactly accurate because they didn't have a trans person or consult with a trans person on this article. Next slide. So this slide shows me when I was on dialysis getting 1 million tubes of blood taken, and then on the left, a picture of my wife and I. And this slide is about LGBTQ plus affirmative care. So SGM affirmative care is more than pronouns. I hear pronouns talked about all the time. I'm glad that you get pronouns. That's great. But it is more in that too. In most cases, I don't think physicians are being facetious, but they have not received adequate training on working with SGM people, and specifically working with SGM people with complex medical histories and disabilities. We know that care is lacking. Care is about, SGM competent care is really about recognizing and providing care that is compassionate and reflects an understanding of the unique needs that SGM people have. It is also about including patients in the process of diagnosis to treatment. So it's not about just stopping testosterone in my case. Excuse me. In my journey, I have found that primary care physicians are increasingly getting better at competent care, but that specialties still struggle with these issues. So when you have complex medical histories or disabilities, you run into barriers, similar to what Shane was talking about. Next slide. So I've talked about a few of the challenges that I've experienced, but I just wanted to talk about some others that give you a sense of it's not just about pronouns. So I often tell people that there is so much more about pronouns. And here are some of the things that I have experienced. A radiologist announced to me that they had discovered my kidney problem because, quote, "you are a man with a uterus." I had a radiologist refuse to give me an ultrasound after discovering I was a transgender man because, quote, "she doesn't feel comfortable with those," is what she said as she walked out the room. And I was stuck in the room for another 30 minutes while they tried to figure out who was going to give me an ultrasound. I was asked by a physician if having Kawasaki's disease was connected to taking testosterone. I was 2 when I had Kawasaki's disease. I was not taking testosterone. I had to undergo a biopsy in Texas and I was not given any pain meds when I asked for them. And I was told, quote, "you want to be a man now, you can be tough." I was asked by a physician why a straight woman, my wife, would be with a transgender man. I was in the ER for a severe headache at that time. I was asked by a physician how I caused my kidney disease and if it could be because gay people have deviant lifestyles. He literally said, "I bet there's more kidney disease among gays because they are more promiscuous." I was hospitalized once in Michigan for a kidney biopsy. I was literally placed in a room with a man. Okay. Then abruptly, I was moved to a room with a woman after I informed the nurse that I couldn't use the portable urinal because I was a transgender man. I was then discharged a few hours later because, well, "you would likely be more comfortable recovering at home," although the initial recommendation was I would have to finish at night. So these are just some of my experiences. And what I want to highlight in here is that I am a fully employed, highly educated transgender man with a female presenting partner. I have always had good health insurance and I have a very supportive family. So I have all the resources and the tools, and it's still navigating the system is really, really hard. Next slide. So just a couple more things. So this slide, the picture is showing some of my bracelets I've had in terms of being hospitalized a few times, and then a picture of me looking kind of annoyed while in the hospital wearing a gown. So this is about access and care. So in fact, about 2 weeks ago, my wife drove me from Bellingham to Seattle, nearly 2 hours away, to go to the ER after I was in urgent care and an ER visit was recommended. The reality is that I've not received the best care up here in Bellingham because of my multiple identities and disabilities. Most of the time, they feel like my case is too complicated and they want to immediately admit me. It doesn't matter if I show up with a cold or something more complex. So as Shane discussed, LGBTQ plus people have higher rates of disability. As a sociologist, I would argue that some of this is because within our community, we take disability seriously. I feel like there's less stigma within the queer community around talking about disability. We create spaces to talk about it and we share resources with others. And that's largely because we have to, right? So what drives this? I think some of that even goes back to before the AIDS crisis, whereas there's ableist microaggressions, heterosexism, harassment. There's a number of things that bind us together in this. So remember when I said I didn't get a kidney diagnosis until I was in stage 4 kidney disease? Largely that was because I was afraid of seeking medical care, and I would only seek medical care if it was absolutely necessary. Like I said, with the ear infection, I had to literally be in the place where I couldn't hardly get out of bed before I would seek medical care. Okay, last slide. Second to last slide. The bottom right picture is me right after I got a kidney transplant, and the top picture is me when I got my PhD. So I want to talk a little bit about disclosure with disabilities. What I have found as a person with multiple disabilities and quote, complex identities, that sometimes people feel like I am too much. And I feel like this is a statement that we heard in the first presentation as well. So as Shane noted, LGBTQ plus people with disabilities often face higher rates of discrimination, PTSD, and anxiety. As a sociologist and from numerous studies I have read, so much of this has to do with social stigma around interconnected identities just being too much. So let me tell you a little story about my experience with disability disclosure, discrimination, graduate school, and being too much. I think the story is important because many of us are teachers in some capacity, and we are training people how to support people with disabilities, or in some cases, reject people with disabilities. Our students watch us as teachers to see how to engage in the workplace in the future. When we deny accommodations or belittle multiple identities, we set a precedent for how our students will interact in the future. When I was in graduate school, there was no medical leave for graduate students, and disclosing disabilities was extremely frowned upon because you were seen as weak. I was told numerous times that my disabilities and identities would be too much for me to finish my dissertation, get a job, and be a successful academic. I internalized this. I didn't mention my disabilities. I didn't ask for accommodations until I absolutely had to. And this was when I was scheduled to have a kidney transplant. I contacted the chair of my department to request a semester off and to get an extension on the timeline because I was literally getting an organ transplant. He said that he could not make special accommodations for me or any other student, and that if I was committed to the program, I would make it a priority. I had already published 15 articles as a graduate student at that point, so clearly it was a priority. So instead of taking time off to get an organ transplant, I taught online courses and was a research assistant that semester. I sent my students a message the morning I was getting a transplant, and I started grading papers and reading emails 3 days later. I remained silent. After the transplant, it was recommended that I not fly for a period of time because I was immunocompromised. I requested that I be able to defend my dissertation online virtually. That request was denied. Of course, it was pre-COVID, so maybe things would be different now. Who knows? I was told that I must defend in person, and I must do so within 2 days after my flight restriction was lifted, or I would be removed from the program. I internalized this experience further and did not disclose my medical history or needs after I left graduate school. After defending my dissertation, I refused to check the box, "Do you have a disability?" I would not take on that label. It was only after gaining my current job and gaining tenure, 2 years into this job for exceptional performance, that I started to become vocal about my disabilities and identities. I had been vocal about having a transplant, but I had not been vocal about the disability component. Next slide. So I'm going to stop it there. Here's my contact information. These are some pictures. I have a picture of me and my donor, a picture right after I got a transplant, a picture of my friends made a kidney cake, and then we cut it open to celebrate getting a kidney transplant. So we had a kidney party. And in closing, the statistics that Shane presented give a snapshot of the challenges faced by many LGBTQ plus people with disabilities. And I hope my story puts a face on some of those statistics and encourages all of us to really think about how we address the needs of LGBTQ plus people with disabilities in our own work, in our workplaces, and in our research. Thank you.
Great, thank you both for your amazing presentations. Both everything that both of you shared is so powerful and motivating in terms of areas that we need to address and make change in. Dovetailing off of that, both of you had mentioned about the need for increased cultural competency and trainings and how we might be able to address that. One of the questions from our attendees specifically addresses this and asks if you might be able to expand on ways that you foresee developing such content and how this might be implemented. Do you think this would be through national advocacy organizations or staff at specific facilities? Are there opportunities for grants where patients and LGBTQ people might be involved in developing this?
Shane, do you want to start with that and I can follow up?
Sure. Yeah, that's a great question. So I think building from some experience. So like in the Pride study we have, so it's a community engaged participatory study. Essentially, that means that we have like a research action committee and a participant action committee. And both committees are made up of people from a variety of backgrounds and experiences within the LGBTQ group. So a lot of those individuals are kind of doing that advocacy on the front line in their own like areas of expertise potentially. But I would say, start having these conversations at your facility, right? I think this sometimes we want to think nationally, and I think this was brought up in the last session, which is a great tool to think about, like these NIH funding, other research grants that can create tools and toolkits for providers to have like an education series or modules, etc. But I think like the action really has to happen and the conversation has to happen like where you're at and in your facility. And I think because each facility is so unique, each medical center, each medical care system is so unique that often you want to leverage the skills that people have in your own facility, create like a little subcommittee and maybe start understanding what the needs are at that facility. We did a similar thing when I was at VA Palo Alto, actually at the SCID center, and Dr. Oda was my supervisor. So it was an interesting approach to use cultural competency committee standards to actually impart education sessions to staff and bring awareness to them about why these things matter and how they matter, and really creating that educational awareness piece. I think awareness is one step further to really create some action because people start to think and mull around why it's actually important and oh, like that makes sense. Like now I can actually do something about it. So that was from my own experience being in a medical center and now being more in like a program office. Cam, I'll pass it back to you now.
Yeah, I'll try to make this really brief, but we always want to do these online educational things, which I think, give like a very basic level, introductory level. What I have found in doing this work and going to a number of different hospitals and different programs and talking to students, that it's really important to have those one-on-one conversations because there's a lot of things that students want to ask or want to understand that they can't ask their screen, right? And that their instructor or the book may not understand or know. There's so many nuances when working with SGM populations that we don't talk about. So we really hold on to these simple things like pronouns, right? And there's so much more nuance in that. And so I think having real programs where you bring in real people and you sit down and have conversations about experience on both ends. What is it like to be the doctor? What are you having to manage in some of these situations? And then what is it like to be the patient? And how do we come up with a system that works together? I think it's really important. Okay, I'll stop there.
Great, thank you. Yeah, I think it's so important, like you said, that putting a human face to the data. So to have both the storytelling component and the research data kind of to drive it and support it. And I think the work, particularly the Pride study, has been doing has been really great, as you mentioned, in terms of community engagement. In her opening, Dr. Sweener mentioned this idea of disability data justice, involving disabled people in coming up with the research questions, in how the data is collected, and then how that data is used. And I think all those things are so important. And the Pride study is very much doing many of those, approaching things with many of those same principles. The idea of nothing about us without us, really involving people in their own research. We're getting close to time, but I have one more question for you, Dr. Whitley. You thank you again for sharing many painful experiences that you had. But I was wondering if you might be able to talk about some protective factors and positive experiences that have come out of your identities and how those have impacted other parts of your experience.
Sure. I mean, I'll keep this kind of medical related. So, you know, when I first was transferred over to the University of Pennsylvania, and I will name it, the institution, I was profoundly surprised that the first time I interacted with a doctor, I didn't have to talk about my trans history. and that we could talk about disabilities being connected and medical stuff being connected, but the center feature wasn't me being trans or me being on testosterone. And that was a really beautiful thing. And it got to the point where, and even here where I am now in Seattle, where I don't even think about myself as trans, so I can focus on my other medical care. Like I don't have to worry so much about that, so I can focus on how do we navigate these different components of the medical care that I need without this being like a barrier or a thing that I have to think about or worry about or, be concerned about. In terms of my identity, I wouldn't change anything about myself. I will just say that. I wouldn't change anything about my history. I wouldn't change anything about, I think being a trans person with disabilities, with a kidney transplant, with these things, I've had a really beautiful experience in terms of life and understanding how connected the queer community is. I've been really fortunate to be in such a vibrant queer community where every step of the way, my community has really been wonderful with me. Even when I needed a kidney transplant, I just put it on Facebook one day and was like, hey, look, this is happening. I don't understand all this. It would be great if I had a donor. I had over 70 people immediately sign up to donate a kidney. So I've just been so fortunate in life because of some of these identities as well, and had beautiful communities and places like this to be involved. So that's what I would say about that. Yeah.
Okay, thank you so much. Yeah, I think through the adversity, I think that there are many opportunities for growth and beautiful things to kind of grow out of it. The sense of community that we're able to form with one another is certainly one of them. Kind of related to that, we're going into a break, but I really quickly wanted to share a resource with everyone. This is a support group for LGBTQI folks living with disabilities. It is available virtually. I'll upload this PDF to the box of resources, but just want to give folks a chance to take a quick look at this if this is something of interest to you. We'll be heading now into a break time before our third session. But again, I'd really like to thank Shane and Cam, both of you, for sharing with us in your fantastic presentations. All right, everybody else, please take some time. We'll reconvene at 10:10, I believe. So thank you so much.
Thank you. And you did forget to mention briefly that the last slide of the slide deck had some more resources. So Dr. Sutha shared that the flyer, it's also embedded on the last slide of our talk. So sorry about not being able to screen share that. But thank you again, Dr. Sutha and the conference organizers for this opportunity.